Community health workers are a bridge between social and clinical care and serve as an invaluable part of the workforce for hospitals and health systems. They provide essential outreach, education, informal counseling, social support, and advocacy to populations dealing with unmet social needs, vital services that often go beyond the professional scope of clinical care teams. In New York City, Montefiore has taken its appreciation for community health workers to a new level, creating an institute to standardize their training and ensure that the patients it serves are getting the best possible care in the hospital and beyond. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hetterly with AHA Communications. Montefiore's Community Health Worker Institute was launched in the summer of 2021 as an expanded investment in how the health system recruits, trains, and integrates community health workers into clinical care teams, where they offer needed expertise in dealing with social determinants of health. In this podcast, Rebecca Chicky, Senior Director of Behavioral Health, Clinical Affairs, and Workforce with AHA, speaks with two experts from Montefiore about how its institute is achieving its goals by improving access to health care for disadvantaged populations. Renee Whiskey-LaLanne is Director of Community Partnerships at the Community Health Systems Lab at Montefiore's Albert Einstein College of Medicine, and her colleague, Dr. Kevin Fiori, is Vice Chair of Community Health and Engagement. Let's join them.
Thank you, Tom. It's an honor today to be here with two wonderful experts from Montefiore, Kevin and Renee. Thank you for your time and, most importantly, your willingness to share your expertise. So my first question to you today, can you describe Montefiore's Community Health Worker Institute, specifically why it was created and how long it's been in existence? Renee, I think I'll turn that one to you.
Thank you, Rebecca. We officially launched in July of 2021 and saw our first patient in June 2022. But I think it's important for us to just talk about our history with working with community health workers. Montefiore Einstein has worked with community health workers since the 1970s and in various models, mostly in part working with community-based organizations to employ community health workers and work in partnership with our system to serve our patients. But this institute is really a new approach. This is a new standardized full investment into standardizing how we recruit, train, professionalize, and integrate community health workers onto clinical teams to help address health-related social needs for our patients. The model is really a solution to a problem that our health system has. We don't really have expertise or haven't in the past had expertise on clinical teams for how to address these social needs. And we see community health workers as a premium solution for how we do that, but also as an investment in workforce. It's really working with community members to solve a problem and working alongside them to professionalize them and grow the healthcare workforce within our system.
Wow. Not only have you been at this since the 1970s, but now you are refining, enhancing, and expanding the work. That is great. And it's also a heavy lift. So, Kevin, I'm going to turn to you and say, so where did you start on your journey to create this program? What were some of your first steps for those who might want to follow in your footsteps? And how was hospital leadership involved?
It's a great question, Rebecca. And I would say, just to follow up a little bit on what Renee mentioned, we've learned a lot as a health system on how to do this well and also some of the mistakes that we've made in the past. And I think one of the big things that we've learned and really initiated sort of the genesis of this newer version of community health workers within our health system is the idea that, we wanted to think about a workforce that could support a family unit. And what I mean by that, a family unit who doesn't look at our health system as internal medicine, pediatrics, obstetrics and gynecology, but really it's coming to our health system. And so we needed a way to have a workforce that could follow families and support families across these silos that we have just by the nature of medicine, of clinical medicine. So what happened was, in the wake of the acute start of COVID in New York City, and the Bronx was a place that got hit particularly hard, we saw a immediate need to do a better job in terms of supporting families who had these unmet social needs. We had social needs before COVID started, of course, in Bronx County, New York, but in the immediate wake of COVID, we just saw a dramatic shift. And so that initiated a conversation with our health system leadership about, we need a new approach. How are we going to deal with this? We already have, overwhelmed clinical teams with our nurses, our social workers, our clinicians. And so just adding to the list of things that they do was not an acceptable, solution. And so we really looked at, well, what are the assets that we already have in our community? And you don't have to look very far in the Bronx. You see, because they come into our clinics, patients who have amazing, expertise in how to navigate sort of the existing resource landscape. And so the idea was, well, how can we better integrate them within our health system? And we knew to be able to do that, we had to have a centralized structure. That was an idea that we pitched to our chief medical officer, Andrew Racine. And his response was, what do you need? How can we do this? How do we invest in this? And so that journey started in 2021. And the other thing I'll say about where our journey started is we were thinking about this as we needed to develop a program that could be scaled across our enterprise. So we were not looking to set up a one clinic, one practice, one hospital solution, but how does a health system integrate this workforce across our enterprise in hematology, in pediatrics? And so to do that, we knew we needed a centralized structure.
You just said several phenomenal words: scalable, coordination, pushing down silos. I don't think you used it, but the term integration of this individual who is going to support the family unit. All of those are, I think, things that every hospital and health system aspires to. So each of us may approach it in a different way, but this community health worker training program sounds phenomenal. You also mentioned the term investment. And so my next question, and Kevin, I'm going to stick with you for a moment. Is this program, this training program of community health workers, is it financially viable? Because the reality is no margin, no mission. And so how have you been able to support and begin to scale this work?
It's a great question, Rebecca. And I think it is probably a central question. And it was the first question that we asked when we started. Just to take one step back, I have been involved with setting up community health worker programs, across the globe for the past 20 years. And my observation is that what we usually do is we just try to put the program into place and think about like how we're going to pay for it afterwards. That there's immediate need, there is a fire, let's grab a bucket of water and put it out. And we didn't do that this time around. And so what we did was we thought through, okay, what are the kinds of things that we think our CHWs will help our health system do better? And our initial focus was looking at missed primary care appointments. We had seen in our data that patients who endorse health-related social needs, they were missing more appointments than patients that did not. And that missed appointment is a fixed loss for our health system. It's bad for the patient. They don't get the care that they need. In addition, another patient doesn't get the care that they need as well, because we usually can't rebook that appointment right away. And we lose, $200 to $300 every time that happens because of our fixed costs. So we modeled the program thinking through how many missed appointments could a community health worker program, a high functioning community health worker program, could it avert? And we started developing the business case for CHWs. So this was in 2021. And then we had some great policy changes that happened in New York State this year, whereby CHW services are now reimbursable under Medicaid. And there's also a program within Medicare. And so we are now, because these reimbursement options are new, we are now putting that into our business model as well, and thinking through both in terms of just the reimbursement revenue that we could anticipate from the services that CHWs are providing, but also the reduction in waste and costs and improvement in care that a CHW workforce could provide as well. So we're looking at all these things, and we actually believe that CHW programs are viable. And not only are they viable, they're probably essential, because whether we like it or not, our patients are coming to us with these health-related social needs. So the question becomes, well, it's affecting our ability to take the best care of the patient. Who on our team do we want doing this? Do we want the MD to take up the little bit of time that they have to do this? Or do we want to take someone who already has expertise because of the shared lived experience with patients, because they've navigated some of these services themselves, bring that onto our team, and it's just a much better business option. So it checks both boxes. It's both in what we think is the most effective strategy for navigating social services, but it's also the most cost effective.
That's exceptional. You are singing a song that I love. You know, you planned, you looked at the cost avoidance opportunities, and there are probably many more that you didn't mention. Reduced readmissions, reduced visits to the emergency department, and then even reaching out, improved productivity for that individual or their family members in their own workplace. The savings can abound with this type of work. It's just often hard to quantify. Renee, can you share some of the other key success factors to making this training program work and grow?
There are a couple of critical key elements that we have to think about. And one was really making sure that we had a clear, established, standardized workflow, one that would be easy to implement, one that we could clearly establish who's doing what and how best to work with your community health worker on your clinical team. And those workflows can really be adapted based on the clinical setting. And so if you're working in the cancer center or you're working in primary care, you can make adaptations based on the clinical context. But it really helps set the guidelines and baseline for how are we going to do the things that we say we're going to do. The other is we're working very closely with identified provider champions who really help us push this work forward. They help us as problem solvers on the clinical care team. Most of our clinical teams are not really familiar with how to work with community health workers or what a community health worker role is. And so we identify these provider champions, we educate them first, and they help us pass the message and really endorse why we're doing this and how best to work with this new member of the team. The other things I think are really important are one, we use data to inform what we're doing. So we want to know of all the data we're collecting, how does this data tell us what we're doing well and what areas we need to improve in? And we use that as a springboard to help improve our program as we grow and we continue to implement. And last but certainly not least is our work around partnerships. From the very beginning, we're thinking about how can we work with community-based organizations, healthcare training organizations, and pipeline programs to really help us identify how we recruit the right types of community members to fill these roles. How do we best train our community health workers? How do we optimize what they're doing? And then how do we provide the best service delivery? And so partners are really working with us from the inception straight through implementation. And I think that is a really critical part of this is to have that feedback and continuous improvement mindset.
If I can, I just want to add to something that Renee said. We were very deliberate and are still very deliberate about taking a learning health system approach, knowing that we're not going to get this perfect at the start, and we still don't have a perfect implementation, and we know that there's always an opportunity for improvement. But the way that one does that, in our team's mind, is we need data. We need data to understand where we're doing things well, but more importantly, we need data to understand where we're not doing well.
So I think in your own words, you just described a sort of a performance improvement process. because there are going to be mistakes, and that's actually a good thing because I can't remember who said it first, but apparently we learn more from our mistakes than our success, and that's what science is all about. So thank you for reinforcing the value of data and taking action from the data when you identify something that can be better than it was. As we go to the last question and wrap up today's podcast, I want to focus in on what do you want for all of those people listening to this podcast? If there were three things to take away, what would you want them to remember to leave with the listeners as we close this out?
So, three things is hard, but I will start with I think the first is, integrating community health workers into clinical teams is really critical. That's number one. It's also very challenging and it requires the appropriate amount of investment. So, I think that would be my first takeaway. The second is there are some things that we've learned that are key elements of success that are agnostic of setting. So it doesn't matter whether you have a community health worker here at Montefiore Einstein or at another institution down the road. I think you have to think about one, clearly defining what the role is, establishing clear guidelines and workflows around how you're going to utilize your community health workers and integrate them into teams and establish that communication between them and everyone else on the team so that this works well. Setting up a foundation for appropriate training, supervision, mentorship, and coaching, and making the business case for why it is a valuable investment to have a community health worker, a local expert on clinical care teams.
I think as health systems, we need to just think about there is enormous potential with this workforce and actually acknowledging the expertise that our communities bring to health service delivery. But it's not just, let's put out a job description for CHWs, community health workers, and some kind of magic happens once you hire them. Really takes an investment, it takes structures. And that's something that we're absolutely committed to. And we're seeing the benefits of that.
Thank you so much, Kevin and Renee. This was exceptional. For those listening in, I just want to let you know, of course, this will be on AHA's Advancing Health channel, and we will do our best to embed a couple of stories, which is where I learned about this wonderful program, because they've been recognized as leaders in this field. And I want any of the listeners who want more information on this wonderful program that you have to have the most available. So we'll get that posted with. So thank you for listening today. Thank you for sharing, Kevin and Renee, for sharing this journey, and best of luck as you continue to invest, train, and mentor this important component of whole person care. Thank you.
Thanks for listening to Advancing Health. Please subscribe and rate us 5 stars on Apple Podcasts, Spotify, or wherever you get your podcasts.